Hello everyone. Today we are going to learn one more important topic, that is how to approach to a patient with hematuria. So hematuria can be gross or it can be microscopic. When we will say that hematuria is gross, so gross hematuria is visible to naked eye. It is suspected when urine color is red or brown. So gross hematuria is visible to naked eye. Microscopic hematuria is only detectable by microscopic examination. More than 3 RBCs per high power field are sufficient to detect or to diagnose microscopic hematuria. So hematuria can be gross or microscopic. Gross hematuria is visible to naked eye. The urine color will turn to red or brown in case of gross hematuria. So how to approach to a patient with red or brown urine? Red or brown urine not always is hematuria. It can be rhabdomyolysis, or it can be myoglobinuria, or it can be hemoglobinuria. So not all the red or brown urine is hematuria. So how we will differentiate between hematuria, hemoglobinuria or myoglobinuria? So we will centrifuge the urinary sample. If the sediment is red, so it points towards hematuria. If the supranatant is red, we will do dipstick test for heme. If this dipstick test is negative, so it can be bacteria or porphyria. If dipstick test for heme is positive, it can be myoglobinuria or hemoglobinuria. So first we will centrifuge the urine sample. If the sediment is red, it is hematuria. If sediment came out red, it is hematuria. If supranatant is red, then we will do dipstick test for heme. If dipstick test is negative for heme, then it rules out myoglobinuria, hemoglobinuria and hematuria. If dipstick test is positive, then it can be hematuria or it can be myoglobinuria or hemoglobinuria. So dipstick test will be positive for hematuria, myoglobinuria and hemoglobinuria as it detects free heme. So we'll do a dipstick test. If it came positive, it can be myoglobinuria or hemoglobinuria. Then we'll look for the plasma color. If plasma color is clear, so it points towards myoglobinuria. If it is red, then it points toward hemoglobinuria. So myoglobinuria is seen in rhabdomyolysis, hemoglobinuria is seen in intravascular hemolysis. In cases of intravascular hemolysis, it can also seen in case of Plasmodium falciparum infection. So how we will approach to a patient with red or brown urine? First we will centrifuge the urinary sample. If sediment is red, then it is hematuria. If supernatant is red, then we will go for dipstick heme. If it is negative, then it rules out myoglobinuria and hemoglobinuria. If it is positive, then we will look for the plasma color. If it is clear, then it is hemoglobinuria. If it is red, then if the plasma color is clear, then it is myoglobinuria. If it is red, then it is hemoglobinuria. So now we will discuss about the various causes of hematuria. So every time you are going to learn some causes, like in case of hematuria we will discuss the causes between glomerular diseases and non-glomerular diseases. Likewise, if you have to learn the causes of proteinuria, then divide it accordingly. Glomerular proteinuria, or it can be related to infections, or it can be related to some bladder conditions, or some some bladder conditions. So always divide the causes into different things. So in case of hematuria can be glomerular or it can be non-glomerular. First we will discuss about the glomerular causes of hematuria. So in case of glomerular causes, hematuria can be immune complex mediated. There are many autoimmune conditions that involve the kidneys and results into hematuria, like IgA nephropathy, IgA vasculitis, lupus nephritis, and post streptococcal glomerulonephritis. Patient will after 2 to 3 weeks of throat infection, patient will present to you with hypertension, microscopic hematuria or pedal edema. Then we can make a diagnosis of post streptococcal glomerulonephritis. So in glomerular diseases, hematuria can be related to immune complex mediated diseases like IgA nephropathy, IgA vasculitis, lupus nephritis or post-streptococcal glomerulonephritis. Anti-GBM disease, Alport syndrome can present as hematuria. Alport syndrome, patient will present to you uh, a child with sensory neural hearing loss with renal involvement can have hematuria. You can make a diagnosis of anti-GBM disease or Alport syndrome. Then there another is ANCA associated vasculitis. Polyangiitis with granulomatosis can involve glomerulus. They can result into hematuria. Church-Strauss syndrome. So these are the glomerular conditions which results into hematuria. So always divide the causes into glomerular and non-glomerular diseases. So in glomerular diseases, it can be immune complex associated, anti-GBM disease or ANCA associated vasculitis. Now coming to non-glomerular causes of hematuria. So in non-glomerular diseases, we will divide the causes into renal, then ureter and bladder, and then some unknown causes. So in case of renal causes which are not related to glomerular disease, they can be pyelonephritis which can result into hematuria. Renal cell carcinoma and polycystic kidney disease can also present with hematuria. Polycystic kidney disease. So in a patient of polycystic kidney disease, if the patient has microscopic hematuria, always rule out cyst infection in these patients. So in kidney, non-glomerular disease involve pyelonephritis, renal cell carcinoma and polycystic kidney disease. Then next moving to ureter and bladder. In ureter or bladder diseases, UTI is common cause of hematuria and proteinuria also. In elderly, always rule out urothelial cancer. In case of visible hematuria, the most common cause in elderly is urothelial cancer. But if even the hematuria is microscopic, always rule out urothelial cancer. Then nephrolithiasis and urolithiasis are important cause of hematuria. So we have to take history very carefully. We have to ask the patient about the symptoms of UTI like dysuria or increased frequency of urination, lower abdominal pain, flank pain. So always inspect about the symptoms of urinary tract infection. In case of nephrolithiasis, flank pain, pain radiating to groin is very common in ureteral stones. Hemorrhagic cystitis, which is a known side effect of cyclophosphamide, and hematuria can be seen after traumatic Foley's insertion. So these are the causes which are related to ureter or bladder. Now coming to prostate. So in prostate, most commonly BPH is also can present as microscopic hematuria, but always rule out prostate cancer in elderly patients. If you have made the, as a clinician, if you have made the diagnosis of BPH, but in elderly, to rule out prostate cancer is very important in case of hematuria. So there can exercise induced hematuria also present. So what are hematuria mimics? What are the things that can mimic hematuria? Like we have already discussed, myoglobinuria, globin in case of rhabdomyolysis, hematuria, or brute mimic the hematuria. So these are the various causes of hematuria. We have divided into glomerular causes and non-glomerular causes. So what are the 5 most common causes of hematuria? So first is most common is urinary tract infection. Common FPSs and BPH is common. Hematuria is most common. So it is better to repeat urine analysis in patient after 4 to 6 weeks, or it can be idiopathic. So the 4 or 5 most common causes of hematuria are UTI, prolithiasis, BPH, post-exertional or idiopathic. These are the different causes of hematuria. Now we will move to how to approach to a patient with hematuria. So like I have already said, always rule out urothelial malignancies in case of microscopic or visible hematuria in elderly patient more than 40 years, and if risk factors for urothelial cancer are present like smoking, male sex, history of pelvic irradiation. So if risk factors are present, always refer the patient to urologist for cystoscopy or for USG or CT scan. So how to approach to a patient with hematuria? So like first we have to do urine analysis. If on urine analysis blood is present but there is no RBCs, then we have to do dipstick for heme. If it is positive, it will be it can be rhabdomyolysis or hemolysis like we have already discussed. If it is negative, it can be due to beetroot injection or porphyrias. So urine analysis is a very important part to rule out, to diagnose renal diseases. So next, if on urine analysis blood is present and RBC cast are present or dysmorphic RBCs are present, plus minus if hematuria is present, so it will point towards glomerular diseases, glomerulonephritis like we have already discussed. So we will send a autoimmune panel to rule out glomerular diseases and complement levels, ANA, anti-double stranded DNA levels, HIV, HBV, HCV serologies. And if the diagnosis remains unclear despite of all these autoimmune panel and significant hematuria persist and there is microscopic hematuria, go for renal biopsy. So if on urine analysis dysmorphic RBCs or RBCs or significant proteinuria is present, so first send the autoimmune panel. If the diagnosis is not made, so consider renal biopsy. Next is if on urine analysis hematuria is present, RBCs are seen but no cast, no proteinuria or any visible clots or present on examination, so then the chances of non-glomerular bleeding is very high. So then we have to rule out the causes of non-glomerular bleeding like we have already discussed. Pyelonephritis, UTI is the most common cause of non-glomerular bleeding or overall hematuria. So we will inspect about the symptoms of UTI. If the patient has dysuria, increased frequency, burning micturition, then we will do a urine culture. If the culture is positive or if there are many pus cells present on urinary examination, then treat for UTI. If there are no symptoms of UTI, next common thing is nephrolithiasis, and ask about the symptoms of nephrolithiasis, flank pain, groin pain. So then go for NCCT abdomen to rule out nephrolithiasis. If no symptoms of UTI or no symptoms of nephrolithiasis, then assess the risk factors for malignancy like we have discussed: smoking, male sex, age more than 40 years. Then we have to rule out malignancy. If moderate to high risk is present, go refer the patient to urologist for cystoscopy, do a renal ultrasound or CT urography plus minus cytology. If despite of all these things, if diagnosis is made, then treat accordingly. If diagnosis is not made despite of these investigations, then refer the patient to nephrologist to rule out glomerular causes or to rule out glomerular bleeding. So if there is low risk for malignancy, suppose the patient is young, 25 to 30 years old male, and there is low risk for malignancy, then repeat urine analysis in 4 to 6 weeks. If hematuria persisted after 4 to 6 weeks, then go for cystoscopy or refer the patient to urologist or nephrologist for further investigations. If there is no microscopic hematuria on repeat urine analysis, then no immediate further workup is necessary. We can advise the patient to repeat urine analysis after 1 year or after an interval of 1 to 2 years. So this is all about how to approach a patient for urine analysis, to approach a patient with hematuria. So key points to carefully look, main key points that you always see in a patient for hematuria is: the most common cause for hematuria is urinary tract infection. Do not directly jump to rare things like autoimmune conditions, lupus nephritis or anything. Just see if there is only hematuria or there is hematuria plus minus proteinuria, whether it is nephritic range proteinuria or nephrotic range proteinuria. So most common cause for hematuria is urinary tract infection. Next is nephrolithiasis, then BPH. But in elderly patient, if risk factors are present, then always rule out urothelial malignancies. So this is all for today. So if you find my video useful, then give it a thumbs up and please subscribe my YouTube channel.